We can test dozens of drugs to really identify which one are likely to be most effective and to rule out those drugs that we really shouldn't expose the patient to because otherwise the patient would only be harmed.
Welcome to Target Cancer Podcast. My name is Dr. Sanjay Juneja. I'm a hematologist and medical oncologist, also known as the Onc Doc on social and news media. And on Target Cancer Podcast, we talk about really the innovative things that are coming to be hopeful about and excited about, because I think mostly everybody is a little either unhappy or wishing that we were doing a better job with cancer. Today's episode kind of addresses things on very opposite ends of that cancer journey, from the very beginning on how do we really cure cancer, as frequently as we can. And, teaser or spoiler alert, we've talked about it multiple times, but this gentleman, Dr. Chris Apfel, is a big believer and studier about all of these things. He has an MD, he has a PhD, he has over 100 publications, he works at UCSF, he's been cited over 2,000 times. And I said, how are you so humble on our pre-call? And I'll give you an idea of his humility. He said, the smartest thing, and I think I'm pretty smart, that I've ever done was to convince my wife to marry me. And he really credits her to be a big piece, as I do myself, of how everything came from there. So with all that said, Dr. Apfel, very excited to have you. Thanks for being here.
Thank you for having me. It's a real pleasure to be on your show.
I appreciate that. And I appreciate everything that you are doing in terms of education. So we get the question a lot, and I'm sure you do too. If you're on an airplane or you're at a dinner and somebody says, hey, that cancer thing, oh, you're in cancer, you think we'll ever cure that? Right? Kind of very reductive in the sense of it's just a binary yes or no. And I'm sure you, like myself, have this portfolio where you have these couple of things, right? These like 10 commandments of how cancer will be cured, right? If you have the steam and time and energy. And one of them is something that we were talking about on our pre-call, which is cancer is most likely to be eradicated and cured if you are able to take care of it early on. The same way that you have a squamous cell that's, a skin cancer or a basal cell or even a melanoma or a wart. You want to take care of that really early on. And then, something a couple of years later may pop on, but it's a much different conversation when it's huge and your dermatologist can't do it and you need a plastic surgeon, or especially if it's gone somewhere else. So take that same concept, and that applies to all cancers. It's just harder because it's not in the skin. And so tell me, if you will, because I love that you had mentioned that, you, for that reason, kind of get excited about things like Grail, which we've had their CMO on our podcast a couple of episodes ago, as well as like imaging, total body imaging, MRI, etc., to the same concept, right? Catch something as early as possible.
Well, and that's exactly right. So we do know that your 5-year survival rates in almost any cancer is at an early stage 1, stage 2, is in the range of 80 to 90%. And so the saying is, a chance to cut is a chance to cure. And so if you can excise it out, you have already won the battle 80-90% of the time. At the time when you have symptoms and you then go to the ER, where it's often not identified and only later on identified months later or sometimes years later, then in stage 3 or stage 4, your 5-year survival goes down to 10 to 20%, and that's not good. And that's with all the best therapies we have currently available. And so what you really want to do is you want to identify it early. And for most cancers, if you think about pancreatic cancer, if you think about ovarian cancer, if you think about gallbladder, if you think of the cancers in its whole entirety, you actually don't find them until the patient is symptomatic, and the patient becomes only symptomatic in stage 3 and stage 4. So what you really want to do is you want to be alert. You want to have your fingers on your pulse, like you're measuring your blood pressure, like you're measuring your glucose levels, whether you are pre-diabetic or not, like you're looking at your BMI. You actually want to make sure everything is in order. If you have your car, you actually bring it for inspection every 2 years. Well, you're not bringing yourself into inspections for every 2 years, right? I mean, so what you can do is so there is now this, and you mentioned now Grail, and I have no financial relationship kind of conflicts of interest here. You mentioned Grail, and they have a blood test where they can actually screen for a wide range of cancers that are usually not screened for, and with 80% of sensitivity overall, and 99.5% specificity, meaning in half a patient out of 100 or 1 out of 200 patients, there may be a false positive signal. In 80% of cases, if you have something, they will actually find it. And we have a case, he actually wanted to have this Prenuvo assay. The first physician said, never heard of it. The second says, well, I've heard of it, but I don't think it's necessary. I won't write for it. So it took him 2 months to get it. And he got the test. And once he got this message, I don't know how many days later, relatively quickly later, he said there is a signal for pancreatic cancer. And you should have a workup there. On the next day, he got a Prenuvo scan. That's a new uprising company that's also currently out of pocket. He got the scan and was confirmed that he has pancreatic cancer. That was about 2 or 3 years ago. He was very proactive in thinking to find the most effective treatment. He ended up getting a cancer vaccine in Japan, and he now has no residual disease.
That's unbelievable,
right? And so those are the things that we need to be aware of. And the current healthcare system is not set up for early detection because the revenue generation is based on treating diseases. We have the highest, the most expensive healthcare in the world, with about 20% of the GDP, and it's incredible. And our outcomes are subpar. We rank in terms of life expectancy at the bottom of the first world, and we have about 30 million people or something like that are still don't have health insurance. Every other first world country has health insurance for everybody.
That's where I really hope someone listening, because it's easy to write off things in a binary way, but that's an immediate fix that enables people to get the things. Because I'm sure everyone's listening, maybe mildly freaking out, right, that they don't have this screening for themselves and their cancer. I get dozens and dozens of texts a day, which if anyone's listening and you're my friend, so I'm sorry I don't always get back on my text message, but it's because they're just legitimate concerns. And they say, where do I get Grail? And then I have to get an ordering physician. But to your point, there is a very hard knot, like in the back, that you can't rub out on how to untangle to be able to make it so that people can get either Grail or imaging modalities to be able to, like a total body MRI, to be able to, locate things. And then we've had a few guests that talk about some metabolic strategies potentially that may be cheaper, where you're able to kind of, give some kind of amino acid or metabolite that cancers kind of uptake more, much like a PET scan, but to do it more affordably. So there is a lot to be done in that capacity. We had Daniel Kraft on this podcast. He has NextMed Health, and him and Scott Penberthy with Google, they both are very interested and, talk with Dr. Leroy Hood often about these wearables and these things that maybe one day in a private capacity, just like you buy an expensive Apple Watch or a Vision Pro, may be able to, outside of the traditional healthcare system, monitor some of these things on a molecular level, or make sequencing fairly affordable, which, Scott Penberthy swears can be done for like $9 now in your living room. So a lot, to be left desirable in that capacity.
Right.
Now, the second thing, because I know that's only a sliver of your brain, is the thing that I also gripe about pretty often is how it's just, if you pull back, a shame that every time I have a stage 4 patient or stage even 3 and try to get them a curative setting, I have to give these abysmal chances of response, right? It's like 60 to 80% if we're lucky in a first line setting. But then sometimes it's mostly in the second and third line, it's a 20 to 40% chance of response. And I hate that because, oh, well, how do I know if I'm responding? Well, it's going to take about 4 to 6 weeks and I have to dump this, kind of damaging chemo in, and then only then we'll know, right? And so that's hard for me to say. And then on top of that, I've worn out your bone marrow so that you don't necessarily have all the, reserve to try that third line or that fourth line, because we only found out that the couple of cycles was not sufficient or effective at killing your tumor. And that's where I got very excited about you, because you have taken an interest in the leveraging AI and the ability with statistical precision. It's not a guess. When you measure something, not to 2 standard deviations, but to 6 or 9, then when you have enough patterns, you have an idea of how something evolves. Just like some of these apps where you can see how you're going to age. If you put in, your picture at 5 and 10 years old and 15 and 20 and 30 and 40, now you're starting to see what you're going to age over time. And you're like, yeah, that's reasonable. Imagine doing that logarithmically higher. And that's what I believe you're looking into, is to say, can we take an environment of the tumor? Because we have, sadly, millions of examples, right, with people cancer all the time. Can we take the yeses it worked, no's it didn't, what happened to the CBC, what happened, there's so many variables for us to dissect. And then you look to see what would happen to that tumor / tumor microenvironment. Because remember, it's not just a free hanging tumor that's out on the beach by itself. It's in the woods and the forest is also your normal cells and your matrix and all these other complicated things. That's almost one of those, books where it says spot the zebra in a bunch of black and white stuff. That's what cancer is a lot of times. And that's what makes it challenging. So if you're able to really evolve this, then maybe I can actually stop having to say you have a 30 to 40% chance and then I'm going to try again, but actually say, hey, we actually longitudinally evolved your tumor and your circumstances. And I can say, hopefully one day with 60 to 80 to 90%, that when we played it out, quote unquote, right, when you use AI to even make the Chicago Bulls of Jordan play the best LeBron team, people are starting to do that now because AI is very statistically sound if you do it right. They're saying who would have won, right? You're doing that in cancer. So I know that's a heavy lift to try to explain in a short amount of time.
I think it's pretty good. And I love your analogies. What I often say to folks, one is not aware that very often if you're diagnosed with cancer, it's hit or miss. And one of the reasons is that even if we do genomic testing, that only in 1 out of 4 patients, we have potentially actionable mutations. Keith Flaherty from Harvard has described it in the Journal of Clinical Oncology. He has reported the results of the National Cancer Institute's MATCH trial, the molecular analysis for therapeutic choice. And what he found is that 26.4% of patients have actionable mutations.
And just to explain that means like actionable meaning something that is either driving the tumor or unique outside of just using generalized chemotherapies that we know is probably sensitive on the tumor type.
Right. And of those 25% or 26%, only 14%, according to Haslam and colleagues, only 14% have an FDA-approved drug for that driver mutation, so that you can give a targeted therapy. And if you give this targeted therapy, objective tumor response rates are only 52% out of those 14%. That actually makes effectively that less 1 out of 10 cancer patients are currently benefiting from targeted therapy, even though we are spending billions of dollars. And it's a much larger market than the whole chemo market, because the whole chemo market are generics. And that's kind of given unselectively. And that's the interesting thing. So I looked into the literature. Is there any better way to find that? And you mentioned that. You mentioned the tumor is actually very complex. And so what I said, when my father was diagnosed with lung cancer, and he refused therapy because when my mother was dealing with ovarian cancer, and he took care of her, and the treatment that she got didn't work in her last months of life. It basically destroyed him. He became an alcoholic. It was tragic. It destroys families. If one of your loved ones is affected with cancer, it's actually also a common course for private bankruptcy, because it is so unbearable. And so one of the things that that he said to me, unless you can tell me, and yet, unless you can promise me this is going to work, I'm not going to have it. And to me, it was a wake-up call. I mean, I've been in clinical research all my life before, and I've done as an anesthesiologist and intensivist. I've published over 100 papers and this and that. And I thought, and I was on the Cancer IRB, the Institutional Review Board at UCSF, at the University of California in San Francisco. And I thought, we have it under control. And what was important for us was always thinking, well, does a patient really get standard of care when the patient enrolls at least standard of care? And now I realize the standard of care is actually pretty low. If only 1 out of 3 patients are responding to therapy, that's very bad. And one of the challenges with genomic testing is it only affects a very small aspect of our cancer. It only looks at the DNA. And that's interesting because, first of all, it's only looking at one mutation. And we do know that, according to the hallmarks of cancers, that before a cancer cell becomes a cancer, there must be many mutations, changing mobility, anti-apoptotic pathways, many other factors influence a cell, or many other mutations have to occur until a cancer becomes a cancer. And so the thinking of, oh, we found one mutation and therefore this drug will work, that's pretty naive. And there are many other things, the gene expression, the proteomics, the metabolomic, and then what you said, the tumor microenvironment that is actually a result of the phenomenon of the extracellular matrix, as well as the cell-cell interactions. And I didn't even plot in here the immune system that also plays a role, that is also affected often by chemotherapy, especially when it's dosed to the maximum tolerated dose, MTD. And so, therefore, just looking at the DNA is very restrictive. Even looking at the transcriptome is still a limited view. And what often is not understood is it's actually looking at dead cells. The biopsy is taken, is put into formalin, and then you try to identify a molecule to understand whether this tumor would have responded to a therapy had the tumor been alive.
No.
And so what I said is, why are we trying it out on the patient instead of taking a biopsy, creating hundreds of replicates in our lab so that we can test in vitro which of the drugs are likely to be most effective. And so that's kind of what we have done, right? So we are now able to create 3D microtumors of the patient's biopsy that retain the microenvironment and the heterogeneity of the biopsy so that we can test dozens of drugs and have a tumor have a response within 7 to 10 days. And we believe this can actually double the patient's chance of a tumor response. This gives you a little visual of how a confocal image of such a tumor can look like. And in lower magnification, you can actually see here, you have basically an untreated cancer and a fully effective drug. And we can measure and quantify with machine learning, etc., how they are responding to the different therapies. And we translate them to a bar chart so that oncologists can actually see what are the most effective treatment options. And I think that's kind of what we really need to be able to help patients. And we believe we can predict tumor resistance with over 90% of accuracy. Because if we are in the dose response, if we have a supraphysiological dose, and we cannot kill, even with very high concentrations, the tumor in vitro, we can be very confident that it cannot work in the patient, and it would only do more harm than good. And so that's the reason why it's important to test it ahead of time in order to understand which therapy is likely to work best.
100%.
And so that's what we embarked on. And so we are now at the stage where we are very excited about the results and the data we are currently getting.
Yeah, no, I mean, the important thing here is that you're taking into account so many variables, which anyone listening, I need you to know, the traditional healthcare system is aware that these are variables, like the extracellular matrix, and then the RNA, and then your own genomics, meaning not your tumors. All of these things are in your own, innate, meaning the GARD and the NK cells and all these different, things. When they say, well, why do we need hematologists? Why did you get that degree? I'm like, bro, there's all kinds of cells and immune cells and hematology that are relevant in cancer as well, not just lymphocytes and things like that. We know they're all relevant. The problem is, and correct me if I'm wrong, is that we really learned about all of these things, genomics and sequencing, all this stuff in the last couple of years. But the way that we built the system prior to genome and NGS is, test and see, test and react. So like it's been that way for 40, 50 years. That's still the way we do things in this country, which is like, we're going to do a trial. We're going to spend, millions and millions or billions of dollars to figure it out. And you're just attacking one. And that's, I don't know how to undo that system. Again, it's this not where if you threw 10, 20 cords for everything on your laptop phone and everything into your backpack and then shook it around, like it's just hard to unravel. But that's the problem and frustration that anyone listening, me as a medical oncologist and my wife, like we're at the handcuffs and mercy of that because that's just what it is. That's how your insurance will cover it. And I think that is on that 10 commandment list of how do we do better with cancer. That's going to be one of them. How do we stop putting you and your specific tumor and your environment into a generalized category based on a cohort of people that were in some kind of study and then real world evidence? They're still all generalizations. What you're looking at is the actual specific tumor and the specific patient. And that's one way to really leverage the incredible machine learning depth and power of technology and AI, because you can say with a high degree of certainty, you spending an entire lifetime in PhD and at UCSF now on statistics and epidemiology and everything that has to do with numbers, you're able to appreciate that. And I think that is just such a necessity. So if I'm not mistaken, to keep that tissue alive in the tumor, you're having to ship that, fairly quickly after the biopsy, correct? Because I believe these tumor biopsies stay alive for about 72 hours or so, correct?
That's about right. Our assay, fortunately, is so robust that we even had results that were very reproducible more than 3 days later. And so that's actually a beauty if it's properly preserved then and cooled, then we actually do have a high level of reproducibility. And there's also, I would like to point out one difference is that in contrast to other companies that are looking at often individual cells, we actually take the whole tumor so that we can also reflect the tumor microenvironment because the whole is more than the sum of its parts. What's interesting is you mentioned the time. Yes, you want the results as quickly as possible. And of course, I would even want to have it in 1 or 2 or 3 days. But the key is to get it reasonably fast so that you can act on it. So 7 to 10 days is plenty of time. The advantage is not only the 7 to 10 days that you within a week you actually have a result instead of
6 weeks.
6 weeks after 2 cycles
with actually just restaging with new images
and
getting the actual
often it's 3 months. The advantage is that we can look at different treatment options at the same time and therefore avoid the wrong treatments. So this one is an example where a mother approached us from a 13-year-old girl with a rhabdomyosarcoma. And the team, so the surgery was on Friday. We got the specimen on Saturday. The team worked the whole weekend testing over 80 drugs and drug combinations. And that was actually quite interesting for me. So they insisted also to test some repurposed drugs. And you may be aware of that there are repurposed drugs such as statins, lovastatin, you can see it here. It actually was coming up to the top of the list of the repurposed drugs. And I wasn't aware of that. And so this is actually a sample we got from this rhabdomyosarcoma patient who has just completed a 9 months treatment with a standard therapy and has developed a lung metastasis. We got that lung metastasis. And we were able to test what makes sense, what doesn't make sense. And the doxorubicin and cyclophosphamide, that in the combination here looks the best, that's great, but it's usually combined with ifosfamide. And ifosfamide has no effectiveness at all, at none of the doses. And so that's actually where we can actually avoid it. It's not that I'm saying we should give lovastatin instead of everything else, but the key is that we can actually pick those drugs that are most effective, and then the other one, they can be added on to maximize basically your outcome.
Yeah. So, that's another key is it's rarely a silver bullet when it comes to a very complex tumor because I'm going to take a step back for a second. Anyone listening needs to appreciate the reason we exist, if you believe, in evolution, is we are very durable in change. So that's why we just don't, freeze up and die when we go out into the mountains or want to climb Mount Everest, which I would never have the discipline to do, or when we're getting hot. Like that's a very simple way of thinking. Okay, we are an adaptive species. We can get our heart rate up. We can sustain high heat. We can, sustain cold and stress and poor sleep. We adapt. Take that and put 10 to the third or fourth or fifth on a cell level. Our cells adapt too. If some simple mutation led to calamity of the function of that cell, then we would have never made it for thousands of years. So there's all kinds of escape mechanisms and kind of backup plans. Like in the same way that, when you hear about NASA and federal government stuff, there's all kinds of fail stops because they take Six Sigma black belt specialists and everyone to say, what is the chance of, something going awry and how do we risk mitigate? Our cells do that insanely deeply. And so that's why combination therapy, and I've always said that on my 10 commandment list, we should probably title this like how cancer will be, a chronic disease or taken control of, and these kind of big highlight points, because that's another one. Multi-combination stuff is hedging your bets. If one thing would fail, I'm also doing 2, 3, or 4, which is why we have quote unquote combination regimens, because you're hedging your bets and trying to attack it from different ways. And we know that statins, and sometimes there's some talk about metformin and other drugs that, surprise, work on us as human and regular cells, also may have an effect or play on your human cell that turned into a cancer. And I get very excited about that in the sense of people discovering that. I think they're looking at that in Shepherd Therapeutics. We had their CEO. They both have personal stories. One had a very rare cancer himself. And now he realized we need more in cancer. And the other co-founder, her husband. And their point was there's other things that affect and take place on tumor kill. Anyone listening, and I want you to think that rhabdo is always not sensitive to ifosfamide, but on your analysis and computational method in this patient-specific circumstance, you had reason to believe that it didn't, right? And that's with statistical likelihood. I also liked what you said about biopsying the lung. And this is a big point. If anyone is listening and you have a loved one with cancer, we live in a world where, at least in community oncology, people are making treatment decisions based on a biopsy from I'm not going to say the full word, a year or two ago, when all the cancer disappeared and you're on maintenance and something comes back, and you're still basing your treatment on the biopsy you got when everything prior to disappearing. That is called tumor evolution. And that means that Siddhartha Mukherjee on our podcast says it didn't escape, and then all of a sudden come anew, that it always existed, that you just couldn't see enough because it wasn't sensitive. It's not that it died and came back. It's that it was never sensitive and you needed enough volume. That's why you biopsied the lung lesion, because this is now something that behaved differently, just like COVID evolves, Delta, Gamma, Omicron. Tumors evolve as well. And I would love, and I probably need a guest here to say, you're a statistical person. Maybe this is another thing you and your wife can figure out. How often is there an AI that can tell us how often we should be rebiopsying, either on the blood or by tissue, to appreciate the likelihood of tumor involvement, meaning that a tumor somewhere else may have different bar graphs than the one you just showed and have different sensitivities, because at this point it's behaving differently. Just like, we were colonized by the British, but we have American culture. The point is, at some point they came over here, right? But we behave differently, and so do tumors. And I would love to know one day, when the rebiopsying increments based on how quickly a cancer replicates, otherwise called grade or Ki-67, that I'm sure factors in to a certain statistical likelihood that a tumor from a significant distance over a significant finite period of time likely has, high reason to biopsy again. That is another one of my commandments on stage 4 setting, where I think, this is how we get a grip on cancer and cancer therapy.
Yeah. And what you say is actually very well examined already found it that this is often can occur. So this is a paper from Gerlinger that you're probably aware of, where multiple locations were actually examined. And what you could see here is basically there are different range of mutation depending on where you are biopsying. And you have here a phylogenetic tree, which mutations are really relevant, or which mutation occur when, so to speak, when the tumor continues to mutate. Now, some tumors continue to mutate relatively fast, right? They with the MSI, the microsatellite instabilities, and that have a deficiency in their repair system. Others are slower, so it really depends on the individual case. And so the question is that you're pointing is how relevant it is. When do you really have to rebiopsy? Because here, while you have a genetic alteration, it doesn't mean that the tumor response is different. Actually, we had an ovarian cancer sample that we received 2 weeks ago, and I can send you the results later, where we actually got it from the primary as well as from the metastasis in the peritoneum. And interestingly, so these are synchronous metastases, the sensitivity and resistance spectrum was virtually identical. Now, for prostate cancers, there is good literature out there that they tend to be very heterogeneous. And as you know, they also tend to metastasize early, as does breast cancer as well. So sometimes there, it could be more likely that the location makes a difference. And there may be others where they are, when you're talking about synchronous metastases that are at the same time, there may still be the same, as opposed to those situations with this girl with the rhabdomyosarcoma, where this may have been the right thing or was actually essential to get the lung biopsy because it already have been 9 months until we had that metastasis showing up.
Yeah. Like they got treatment, the other things responded, and therefore this is behaving differently. I mean, to me, that's the lowest hanging fruit of a no-brainer, which unfortunately still is not uniformly practiced in this country, which is why I stress out and have a lot of gray hairs and have this podcast. Is somebody listening might say, hey, this tumor, you'd mentioned that this is the one that behaved differently, or the ones in the liver were different than everything else in the rest of my body. That's where you may want to consider asking, does it make sense to biopsy my liver, lesion, because they're all doing differently than what was in my lungs and bones, which are all, responding really well. Yeah. And I think there has to be a way one day where AI will help us determine, based on the cancer type, based on the sequencing, DNA and ideally RNA, and based on the volume of disease, how many organs are involved, how many spots, that should spit out a number on likelihood or unlikelihood of seeing something at X amount of time, 6 weeks, 3 months, 6 months, to strongly reconsider biopsy, because there's a high statistical likelihood that something is behaving differently. Like that to me is another on the sheet of commandments is you're going to know and have a nice little, stepwise plan for tumor evolution. It's also why I personally, in my practice, I'm very aggressive about when something is behaving differently. Say someone has 9 spots and 8 respond, and I can't get to one to biopsy it. I try the blood biopsy, but you just can't get to it. It's hard for me to justify changing or stopping the therapy that worked on the other 8 spots in other organs. And I may go pursue for stereotactic radiation because I'm like, that's rogue. For whatever reason, something doesn't work. And that's a strategy a lot of people adopt. But again, it's ill-defined. But fortunately, if you're lucky enough to have the tools, interventional radiology, to use Y90 or chemoembolization, which is a directed therapy to the liver tumor. Do you have a radiation oncologist to do stereotactic to the lung? But that is, again, on the commandment sheet of how we will stay on top of something that really we're battling ourselves, but they just don't get tired. They're on steroids. That's what the cancer cells are compared to regular cells. Regular cells, no one to stop. Your spleen takes your red blood cell. Somebody said, we don't know what the spleen does, and says, thank you for your service. After 150 days, it makes a new one. So all of ours expire. Now you're fighting the sinister, almost like Venom from Spider-Man kind of thing where it just evolves resistance and escape, mechanisms. And every time it duplicates, it's hedging its bets to get resistant to monotherapies. I don't want anyone listening to think, oh my gosh, I'm on a monotherapy for my EGFR positive lung cancer. Am I being naive? Like, please understand, there are circumstances where a single therapy actually is very effective. And there's a lot of study, and I personally, again, on my sheet, I say commandments, whatever your analogy is, on my sheet is there will always be a place for chemotherapy, usually in a first line setting in stage 4, because that also just kills a lot, like ideally kills a lot of colonies that would become problems later. So, and Siddhartha Mukherjee says the same thing, kind of, throw the thing in the house and in the bad player's barracks and have kill the most that you can immediately, because you don't have to worry about them evolving because they die with cytotoxic chemotherapy or generalized, and then start being smart about the targets of the ones that do remain after that initial whack of all, hedging everything away. What remains? Now identify their mutations, try to exploit that, combination therapy, statin, metformin, etc. And then I think the layer that's also neglected is metabolic. Is there something that can be exploited on which resources? Is it an electric car? Is it a gas car? Like, does it need, certain amino acids? Does it need glucose or not? Can it use ketones? That's kind of the way of thinking, of reducing the numbers and then finding out what is unique to the ones that are remaining. And then if you can't break that shield, or it's just, where is Waldo? Too hard to find on the sheet. Then, but Waldo does, he's a picky eater and only eats, red meats. Then try to take away the red meats, and then Waldo may, just starve even though you can't see them.
I love your analogies, and in a way we should have a number of other podcasts that also probably dive into nutrition. You mentioned ketones, so that's an interesting aspect, and I do think it's actually important. I mean, if you think about Jane McClelland, what she has done there, and it would be important to put some data behind that. Now, in this situation, I actually, you're asking me questions. Can I also ask you questions?
Sure.
So, for example, when you have this patient who's responding here but doesn't respond there, do you also, and you can't get to the biopsy. So often you can actually, but let's say you can't. And I like this idea of specific embolizations. Actually, I just brought up an idea on a patient that has actually a breast metastasis to the liver, and the liver is relatively full. After 5 years, it was actually quite dramatic. She was a DCIS, a ductal carcinoma in situ, so stage 0, and she went for double mastectomy, had her follow-up screening, and after 5 years, she insisted on having a whole body MRI, and everybody refused and says, "You don't need it. You're cured. What do you want?" She gets a whole body MRI and has liver mets. And so there, basically the stereotactic infusion specific of chemotherapy into those locations, that actually makes a lot of sense. I don't know why it didn't come up to my mind. So thank you for mentioning that. But to my question to the other point is, you have different metastases. They may develop slightly differently. What do you do? When do you change the therapy? Are you using Signatera or any other liquid biopsy technology to quantify the burden of disease in order to see how the patient is responding? Because I think short of getting the biopsy, what we are doing, and seeing in the lab really how the patient's tumor is responding, if we don't have that, or if we had this initially, we could treat accordingly, we could monitor and kind of see where is actually, how is the tumor coming down with the Signatera. Are you using that in order to make early adjustments? Because this is, as I understand, reacts months earlier than any PET-CT scan.
Absolutely, because remember, a CAT scan, I'm told, if you do general math, I might follow up and ask you to validate this, but it takes 100 million or so cells to see it on a CAT scan. And so PET scan has even less slivers. And a PET scan only lights up with, maybe 6 millimeters, at least on our equipment, depending on how rapid it is. That's why this older way, which is still a way I use all the time because we have to, but to re-image the whole body is not, the most comforting on saying that you don't have disease, because we know if that was the case, then people wouldn't recur, in any cancer type. So to your point, you're getting a much deeper degree of appreciation of what is still active, right, at 3 or 6 months. To answer your question simply, absolutely, I'm rebiopsying. The one that I, will say does it best illustratively is Guardant. So I have every company, box in our clinic, because I have them for different reasons. But I like Guardance, especially when it comes to colorectal, because it colors the lines. So I get to show the patient, I'm like, look, your volume was here. You only had 2 or 3 lines, and look how much they've dramatically come down. But then I show them the other one that's unique, that's the evolved tumor. I'm like, but this sucker is coming back up, which is why I'm switching from FOLFOX to FOLFIRI, because it's coming up despite us being on FOLFOX. But the other stuff may have gone away. And so now I'm strategizing, and I'll write in my note, did not fail FOLFOX per se. You have to get creative, but I chase, in an ideal world, again, on this list of 10 ways that, it'll be a chronic illness, you have to adapt quickly before you see this macro disease on scans or multiple lesions. To your point on the liver patient, for example, I still would definitely biopsy, send it for, a test with SAGE to get an idea of what works and what doesn't. Maybe stereotactic, but truly, stereotactic or not, I would do systemic chemo, because whatever you can see is what you can see, but we're 5 years out. So there's micrometastatic stuff elsewhere. I would not feel comfortable killing the 3 tumors I can see, because I know there's smaller disease elsewhere. So I may do that in combination with systemic disease based on what your thing shows me. I'm going to say, hey, it says these 3-4 things are sensitive, or I feel really good about using XYZ in this setting. I'm going to stack it hard because it's limited to the liver. God willing, it all disappears. And if it doesn't, then maybe follow up with stereotactic, because you avoid liver injury if I'm able to systemically kill what I can see. And then on top of that, anything I can't see. And then if something is being stubborn, at that point, I would go stereotactic, because I got to do that kind of collateral damage to good tissue. But all that to say, I think you did it correctly. But to your point, yes, and to my point earlier that you just reinforced, yes. I think it's very important, and a lot of these companies are realizing that and coming out and saying, well, you can do 3 weeks, 6 weeks, 4 weeks, and I taper that based on, the likelihood of seeing something come up. But in an ideal world, I think you should know the fraction of the allele, you should know which colonies are behaving well and not, and look at the tools you have. Like you said, and we actually had Keith Flaherty, I want to say he was our first podcast guest, believe it or not, or at least one of our first 2 or 3, 2 years ago. But to his point, as far as something actionable outside of systemic chemo, which is in every guideline, you had said 25, I agree. Everyone knows the 25% actionable, but only about 18% have a drug. And then on top of that, 50% chance. So we're talking about 2%. If you don't have that, then I would do a systemic with that tumor evolution. And I think that's how stage 4 patients are staying alive, for 2, 3, 4 years with minimal low burden disease, because this is what it takes. And I think machine learning and AI can really help democratize this. And it all just stresses me out.
Great. Fantastic.
Anything else? So if somebody, Dr. Apfel, if somebody wants, so I have a good friend that has a pretty terrible stubborn disease. He's, without saying so much, and he's fine with me talking, MD, PhD, just a good friend of mine. How does one do this computational testing?
Yeah, so it's actually not only computational, right? So because we do the real stuff, right? We get the biopsy.
Oh, true. Sorry.
Right, and yeah. So it's not just a simulation in the cloud. What we are doing is we're getting the real sample, and that's important to get the fresh live tissue sent to us, so that we can actually see how the patient's tumor is responding. Contact us through our website. We are currently modifying our portal so that the patient can sign up directly. The best thing is probably even to schedule a 20-minute conversation with me, so that we can see, does it make sense for your patient? Or what I sometimes do is we have now more and more oncologists that are referring patients to us directly. And so you can also go to our website and then say, I would like to have the SAGE Oncotest, the standard panel, NCCN guidelines, restricted. So you mentioned that as an oncologist, you have all these shackles on and restrictions.
Yeah.
So what we sometimes do is we say, okay, if you really only want to know something about the drugs that are within standard of care, we can actually restrict it to the panel so that you can provide superior care within standard of care. That's usually for early stage patients. And then when the treatment have failed and we get a biopsy, then we would actually want the extended panel with the repurposed drugs, with the target therapies. We can actually also test target therapies and then go beyond standard of care. And so you would actually make the referral. You would say, do it beyond standard of care. or the extended panel, please, because I want to know, is there anything in the armamentarium that we can use to help this patient?
But then say for my patients here, is it a kit that you all
Yes.
mail that my CT surgeon or IR
We
can put into the tube and send
we
it?
send the kit to you, and then you ship the shipment kit. It's in cooled box, and it's cooled at 4 to 6 degrees, 4 to 8 degrees Celsius, and so it comes in our place and fresh. We also do Saturday deliveries. We want the best possible results. So if the biopsy is on Friday, we even process it on Saturday. We want to make sure that we can maximize the yield of the tumor fragments and create as many microtumors from the patient's biopsy as possible, so that we can test dozens of drugs to really identify which one are likely to be most effective, and to rule out those drugs that we really shouldn't expose the patient to, because otherwise the patient would only be harmed. So that's what we do. Just contact us.
Well, I hope this becomes standard of care everywhere. And I know if there's a statistician and math person that can prove that concept to insurance companies and to the, Medicare and federal, regulations, I know it's you. So I would love to just watch you hand the data to say this is why everyone needs this, at least in a second or third line setting, to really give people, the best shot. So thank you so much, Dr. Apfel. I really hope to follow back up with you and maybe have you back.
Sure. It's been my pleasure. It's really joyful. We have a lot to talk about, I think.
Yes.